My name is Suzanne Rayburn-Burgess, and I'm the Director of Global Customer Relation Management at LAP, Switzerland, and I will be the chairperson of today's session along with Ms. Amal Ibrahim from Jordan. Firstly, I would like to tell you something about the UCG conferences. Utilitarian Conference Gatherings offers a wide range of events, meetings, conferences, workshops, and symposiums. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate with the best ideas and strategies. Utilitarian Conferences Gatherings is a pioneer in the area of event management, collaboration. We are a full-service event provider specializing in the field of medical, clinical healthcare, life sciences, engineering, pharma, environmental science, engineering, business, agriculture, and food event services for academic and the industrial sectors. We stand out distinctively from our competitors for our commitment to quality, round-the-clock service, and unmatched price. We are able to provide you with the best event meeting experiences under one roof. We at the Utilitarian Conference Gathering make sure that you as a client choose the most appropriate event. I thank you now all for finding time in your very busy schedule to be here today. Today marks the major activity in the brief existence of the UCG conference, a moment where we are interacting and sharing experiences and reflecting on various areas. UCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of healthcare, making the online conference a perfect platform for sharing experience, foster collaboration across industry and academia, and evaluate emerging technologies around the globe. We cordially welcome you to join us and witness the advancing in this field all together. The conference has attracted delegates who have come from all over the world, across the continents, and the subject of the conference is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. EPUCG Program Committee has put in long hours with many creative efforts, and finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoy the conference and that your participation will contribute to our professional development and relationships. Please note in the further speech, the speech time for speakers will be 30 minutes. The speech time for keynote speakers will be 50 minutes. And please also be aware that certificates will be provided on April 10th, 2021. Now, swiftly, we will move on to who is going to be keynote speaker today at day one. And therefore, I have the immense pleasure of introducing our keynote speakers at the Healthcare Management, Nursing, and Patient Safety Conference. First, we will hear Ms. Lina Obaid. She's a quality nursing supervisor at Sultan bin Abdulaziz Humanitarian City in Saudi Arabia. Followed by Dr. Essam Ali, Director of Quality and Accreditation in a private hospital in Abu Dhabi, in the UAE. Then there's going to be myself, Suzanne Rayburn-Burgess, and followed by Mr. Dr. Farouk Mirza. He's a consultant healthcare quality and patient safety, certified patient safety trainer at CPSI, Director Mirza Healthcare Associates Incorporated from Toronto in Canada. Then we have Professor James Jordan, President and CEO of Straff Tactic Incorporation in the US. Dr. Sarah Al-Dalal, Senior Health Service Specialist at DHA, also from UAE. Professor Tarek Ali, Professor and Consultant Physician, Internal Medicine at UAE, is a medical expert and lawyer and researcher in medical philosophy. Followed by Dr. Jorge Hidalgo, Head of Intensive Care and COVID-19 Unit at Bdsa Healthcare Partners Limited, Secretary General of World Federation of Intensive and Critical Care Medicine in Belize. Dr. Jamila Ali Al-Hinai, Project Director of NSRD 2040 of Oman. And last but not least, Dr. Jenny Mariam John, Healthcare Development Officer at Dubai Health Authority from the UAEs. Thank you all for this introduction, and now it is my pleasure to actually start and begin with the sessions. I would like to introduce our first keynote speaker, Miss Lina Obaid from Saudi Arabia, and Miss Obaid will provide us with a speech using lean management approach in improved clinical team leader handover process in nursing services. A few words about her. Miss Lina Obaid has completed her bachelor degree in nursing science from Jordan University in 2007, followed by a master's degree in public health from the same university in 2010, and certified by the Jordan Society for Quality as a certified quality master. She is the nursing quality supervisor in Sultan bin Abdul Aziz Humanitarian City. She has facilitated and led more than 20 performance improvement projects by using different quality methodologies. She's one of the keynote speakers at the yearly Nursing Management and Leadership course and Nursing Rehabilitation course. So please, Lina, handing over to you, and we are very, very eager to hear your keynote speech. Please, Lina.
Thank you so much, Susan. I'm trying to open my camera, but I cannot. Just a minute. Yes, okay. So, thank you so much for the introduction, for your kind introduction. I will be sharing my slide with the audience. Okay, I hope you can see my slide.
Yes, perfectly. Thank you so much, Lina.
Okay, great. So good day to all, and it's my pleasure being with you today at the Nursing and Patient Safety Conference that is organized by UCG to share one of our quality improvement report, which is using lean management approach to improve the clinical nursing practice within our facility. So first, allow me to introduce our lovely city to the audience. In Sultan bin Abdulaziz Humanitarian City is one of the largest rehabilitation facility and the best state-of-art medical rehabilitation in Middle East with a capacity of 500 bed capacity and more than 20 inpatient nursing unit with outpatient services. So the city is driven by a person-centered care philosophy toward its patient, and it's strongly supported by leadership and evident in the development and implementation of services, system approach, and interventions. Among these approaches is acknowledging accreditation to continuously improve and contribute to patient safety and the quality of care. And part from this improvement is our quality report, one example out of many other examples. So to move on with our aim from this report is to test the effectivity of lean management approach in improving the duration of clinical handover by eliminating unnecessary steps toward a more efficient, sustainable, and effective communication between the clinical team leaders in nursing units. So why we are selecting lean management or lean approach? Lean is a set of operating philosophy and method that help create a maximum value for patients by reducing the weight and waste. So it's emphasized the consideration of customer needs, employee involvement, and continuous improvements. So let us just speak about the clinical handover or the importance of clinical handover. Clinical handover is referred to transfer the information or transfer the professional responsibility and accountability for some aspect or all aspects for a patient or a group of patients to another person or professional group on a temporary or permanent basis. It is in fact a valuable and essential part on any healthcare organization. However, at our facility, the clinical team leader face a challenging role during the handover due to the prolonged process causing extra nursing hour beyond their schedule. So how did we identify such issues? Through our partnership with the National Database of Nursing Quality Indicator, the services were able to identify one of our area for improvements. During the RN survey of 2019, the 83% of the staff reported that they are working more than or equal 1 extra hour beyond their schedule of 1 hour. So at the city, utilizing all resources and tools to improve nursing practices and the process, one of the major aspects in any other healthcare organization as well. So moreover, improving communication process between healthcare providers were declared as one of the international patient safety goals by the Joint Commission. So a clinician should follow a well-communicated protocols that guide them for well-communicated and transfer of information. So before we move to the lean and the steps and the strategy of lean, I would like to show you a short video from Gimba Walk Academy. We'll introduce the lean concept to the audience, then we will proceed with our tool and the strategy of lean approach.
Hi there, I'm Ron Pereira of Gimba Academy, and I'd like to ask you a question. If someone asked you to explain what lean thinking is all about, what would you say? Well, by the end of this video, you'll understand and be able to explain exactly what lean is and why lean is beneficial for individuals in any sort of organization, no matter the industry. All right, well, let's begin with a definition. Lean is an operational excellence strategy that enables people and organizations to change for the better. Put another way, lean thinking organizations are constantly seeking out ways to continuously improve the way they work. Another common way to define lean is that it's the persistent pursuit and elimination of waste. Now, a few examples of this waste could be the waste of waiting, the waste of defects, and the waste of excess motion, leading to lost productivity and, in extreme cases, injury. And while lean is all about improving processes, its greatest value lies in the development of people, since in the end, lean is a people-based system. Yes, the many tools and concept of lean are important, but if you neglect the people aspect, failure is almost a certainty. In fact, lean is often described as a system focused on creating customer value. Well, the base of the so-called lean house consists of concepts like teamwork, challenge, and kaizen, which means to change for the better. Then there are two pillars that hold the house up. The first is continuous improvement, which represents the many tools and concepts of lean, while the second pillar, respect for people, represents the importance placed on the development of people. To be sure, you can't succeed with lean without both of these pillars firmly in place. Finally, from a definition perspective, it must be said that lean isn't only about attacking waste while increasing the speed at which products are produced. Lean is also very focused on improving the quality of our products and services, as well as the stability of our processes. In fact, many lean principles, such as one-piece flow, will never succeed without stable and high-quality processes in place. So that's how we can define lean. The next question we'd like to address is why so many organizations are using lean to improve their businesses and, more importantly, the lives of their employees and customers. And to answer this, I'd like to ask you a few questions. Have you ever experienced long waiting times at the doctor or any sort of service center? If so, how did it feel? Conversely, have you ever ordered something from your favorite online store and received the item later the same day? If so, how did that feel? Lastly, have you ever purchased something that was made and performed so well that you were forever a loyal customer? Well, obviously, very few people like to waste time waiting, and experiences like same-day delivery and extremely high-quality products are most definitely delighters. And as it turns out, many of the organizations practicing lean see results just like these without resorting to holding excess inventory or expediting or performing excessive visual inspection. It should also be pointed out that these same lean thinking organizations also reap many other benefits, including improved employee engagement and morale, reduced operating costs since employees are constantly seeking out improvements, and improved safety for everyone in the organization. Taken together, all of these improvements ultimately lead to increased profits and long-term success and growth of the organization. And with all of this said, one of the most exciting aspects of the work here at Gemba Academy is hearing lean success stories. For example, our friends over at the FedEx Office Manufacturing Network reduced accuracy failures by 30% from a batch and queue workflow to continuous flow. They also reduced the injury rate by 60% through the application of daily improvements in shift huddles. Next, the folks over at Franciscan Health in Indianapolis, Indiana, began saving more than $30,000 per year when a lean thinking nurse found a better way for endoscopy patients to deal.
Okay, thank you. So out of this video, just a minute to move the slide. Okay, so after this video, we can say that the lean in healthcare is the application of a lean ideas to minimize the waste with the ongoing process. So the finding promoted the team to formulate a core group to investigate and carry out a systematic and formal inquiry to discover and examine the fact of the incident. So the team or the core team started with a Gemba walk. Gemba walk is a Japanese term, which is reflecting to real place or to be on actual place. Gemba walk, it's an opportunity for the staff to stand back from their day-to-day task to walk with the floor of their workplace to identify the wasteful activity. So the objective of Gemba walk is to understand the value stream and its problem rather than review result and make superficial comment. So the team went to the unit to observe and recognize the practices and the waste within the process. So there are 5 recommended golden rules of Gemba Kaizen or Gemba Walk. First is to go to the process or to the actual place to see the process on reality, to observe and to recognize, and to look to the flow of the process. Then to take measures with you, because if you cannot measure it, you cannot improve it. So you need to have some measures. And to know or to identify the ways to find the root cause and to kill it by using or eliminating the 3M, and standardize to prevent the recurrence. So let me highlight the 3M, or to eliminate the 3M. What does that mean? Through Gemba work also, the 3M is reflecting to a term of Moda, Mora, and Morai. And also the three terms were used together in Toyota production system. And I'm sure if we have an attendees with us, experts in Lean, they are aware about the 3M. The Moda is reflecting the wasteful activity, if there is any wasteful activity within the process or the practice. The Mora is reflecting the inconsistency in the system, and Morai is reflecting the physical strains. So when we are going to visit the unit to see, we need to look to the waste to eliminate it. If there is any inconsistency in the system, so we can avoid if it's happening sometimes or in some places or with some people, and to look to the physical strain. If there is like overburdening equipments, issues with the system, because physical strain really reducing the enjoyability and the effectiveness in addition to the efficiency of the staff. So the staff, when they conducted the Gemba walk, they were focusing on the 3M to see the duration of the handover, and this was the main aim for this projects. The type of waste, identify the waste, which is the MODA, the type of defect or gap in the process, and the common practices to see if there is any inconsistencies in the system or practices that the staff are doing. After visiting 50% of the units and attended more than 12 handover process, the team found that the average in all units, it's between the 40 minutes to 60 minutes. So the staff really exceeding the time frame between, or the usual time frame of having the handover between 20 to 30 minutes to exceed up to 1 hour from their schedule. So after listing these findings, the staff went to the second tool of lean management, which is the value stream map. The value stream map is an important element in implementing lean approach. The goal of which are to maximize customer satisfaction, which is our staff, and minimize the waste. Value stream map usually are conducting after the Gemba walk, after attending the process in details with the staff, then coming to draw the value stream map to see the value adding or non-value adding activities by using a certain kind of waste. So again, before I proceed with the tool, to show you the tool or to display the graphical representation of the tool, I would also share with you one video from Gemba Academy as well, sharing with you the 7 deadly waste that is affecting any process within the organization, either in healthcare organization or in industrial organization. So let us watch together, then we will move to the value stream map to discuss more about this tool.
Of Gemba Academy, and I'd like to welcome you to this course that's focused on dealing with the 7 deadly wastes. Now, in this first module, we're going to get things started with an overview of the topic, where we'll learn what the 7 wastes are, allowing us to then build on this knowledge in later modules, where our focus will be on finding ways of eliminating all forms of waste. Well, specifically, by the end of this module, you'll know exactly what it means for an activity to be value-added, non-value added, or waste. And you'll also be able to identify what are commonly referred to as the 7 deadly wastes. Now, throughout this course on the 7 Waste, we'll be visiting RAM Technologies, a custom foam fabricator located in Washington. And while inside their factory, we'll do our best to demonstrate what each of the 7 wastes look like, while also showing what things look like when these wastes are eliminated. But let's go ahead and start things off by discussing the various elements of work. Now, when I say elements, I mean that any work or activity we do can be classified into one of 3 categories. First, we have what we call value-added work. Now, for something to be called value-added, 3 things must exist. The customer must be willing to pay for it. The thing must be changed in some way. In other words, we like to say that when value-added work is done, the form, fit, or function of a thing is changed. And finally, the work must be done right the first time. Now, if any of these 3 points are missing, the step or process cannot be said to be value-added. And while value-added activities are what we prefer to do most of the time, we won't spend much time or effort focusing on value-added steps as it relates to reducing waste. But I'll explain why this is later in the module. Next, non-value-added work is work that adds no value, but must be done to meet the customer's needs under today's conditions. Now, this is a minor area of focus in lean manufacturing since it's harder to improve in this area and there's less of this type of work than the third and final category, which is waste. Waste is also referred to as muda, which adds no value and customers are not willing to pay for it. Now, the best way to understand the impact of waste is to look at work from the customer's viewpoint while asking yourself, would I want to pay for this if I was a customer? Now, even some things that you would be willing to pay for may be done at a cost that's too high or with too many non-essential steps. Now, it could be said that eliminating waste is like defragging a computer. When you defragment a computer, you will rearrange the data so that you can open up space. But when data is fragmented, there are useless bits that are filling up memory, much like the useless amounts of waste taking up space and time within our processes. By identifying where value-added portions are and moving or removing the non-value-added bits, you improve performance of your computer. In the same way, taking waste out of your process improves its performance by radically reducing the time it takes to fulfill a customer request. Now, as we discussed earlier, we prefer to spend most of our time doing value-added work. Unfortunately, when we look at the total lead time through a value stream, we find that a massive amount of muda, or waste, is stealing resources and time. Another unfortunate activity we often see companies doing is attempting to reduce the overall lead time by making the value-added processes more efficient. In other words, as an example, they work to save a few seconds or minutes of machine cycle time in order to reduce the overall lead time. And while this isn't necessarily bad, there's far more opportunity in reducing the waste in the process first before worrying about improving the value-added steps. With all of this said, in order to be able to attack this waste, we must be able to identify it. So let's spend the remainder of this module by discussing what we refer to as the 7 deadly wastes. Now, the first waste is defects, which is simply work that is less than the level the customer, both internal and external, has requested. Now, some examples of defects are rework, scrap, missing parts, wrong parts, and yield loss at startup. Now, as a point of reference, the waste of defects is also sometimes referred to as the waste of correction. Now, in this example, we see that our operator, whose name is Isaac, is struggling to understand his work instructions, and as such, scrap parts have resulted. Next, we come to the waste of inventory, which is any work or material on hand other than what's needed right now to satisfy customer demand. Now, some examples of inventory waste are excess raw materials, work in process, finished goods, supplies, and spare parts. Now, in an upcoming module, we'll spend more time exploring the different types of inventory we might have on hand, such as cycle stock, buffer stock, and safety stock. Now, in this example, we see Isaac surrounded by piles of inventory, making it hard for him to even know what to grab. All right, next we experience the waste of processing, sometimes called over-processing. which is when something's designed in such a way that uses more resources such as space, energy, or people than is truly required. Sort of like using a sledgehammer to smash a peanut. The waste of processing is definitely the hardest to understand and learn to see, since the most common root causes are a lack of understanding of customer needs. Now, some examples of processing waste are machines that are slower or faster than needed, equipment that uses more energy than needed, redundant work such as copying information, drilling a hole instead of punching it, and cleaning something multiple times. Well, here we see Isaac carefully measuring each piece of foam when, as it turns out, these pieces have already been cut to size and don't require such meticulous and time-consuming verification. Next, anytime there's idle time created because materials, machines, or information are not ready for people, we have the waste of waiting. Now, this waste is usually less visible than the others because it's often replaced by overproduction or busy work. So, in fact, when waiting becomes visible, it's important to keep people from working just to keep busy, since this busy work often does more harm than good. Now, some examples of waiting are people waiting for materials, an accountant waiting for information to close the monthly books, warehouse employees waiting on a forklift, or a nurse waiting on important supplies to arrive. Now, in this scene, it seems that Isaac has run out of work and is obviously looking for something to do, so he resorts to his newspaper and text messaging his friends.
Okay, so moving on with our value stream map, the idea from the video was to identify the seven or the waste, the deadly waste in any organization. So later on, after the value stream map, will show you again the kind of waste that the staff detected from the project or during their Gemba walk. So the value stream map, as I have mentioned to you, it's like a graphical presentation will reflect the process. So the staff will start from the step of the process, then they will list the time of each step, then the waste in that step, and the reason for having such steps. So in the general, the value stream map will show you a step by step. Then we'll show you also the input and output of each process, the suppliers, customers, media used, and issue presenting during the process. So even within the green zone, if you can see that the staff calculate the time spending from moving from step to step. So during this Gemba walk, this is the after the Gemba walk, and this was the value map of one of the unit that the staff involved all patients while they are observing the handover of the staff, considering not only the flow of the patient handover, but also looking to the flow of the information, walk through the handover process from the first patient till the end patient, and draw the process from starting point till the end point. Once the team leader arrived to the shift, till the team leader left the shift after endorsement. So the kind of ways that the staff were referred to during the completing their value stream map was using the 8 waste, which is the downtime acronym. The D is standing for defect. They're looking if there is any kind of overproduction, waiting time, non-adding value act by the staff, issues in transportation, issues in inventory, in the motion, employee underutilization, and the team added B as a behavior or reflecting the behavior related to the practice. So after that, the team identified 5 kinds of waste, which is relating to defects, waiting, non-value adding act, employee underutilization, and B related to the behavior or the practice of the staff. So the process mapping in general, as mentioned in the video, also out of the value stream map that the staff built, is to identify the non-adding value activity. Is there any delay point in the process? Is there any duplication of the forms, lack supporting documentation for the staff, inconsistency in the process, and lack of understanding? So the baseline measurement that the staff identified after of the Gemba walk and the value stream map, that they need to look for the standardized practice. There was no standardized practice because the team leader, they were referring to the assigned nurse handover. So they were using the assigned nurse handover also for their handover, which is also causing more redundancy in repeating the information of the handover. Also detailed handover, which is unnecessary to be there. Many external interruptions affect the team leader handover, cutting the handover to answer those interruptions, and lengthy time of narcotic checking due to the high volume of narcotic medication at the narcotic cabinet. So the target selection of the team were to standardize the duration of the handover to have it within 20 to 30 minutes only. So that the team design a target for them for the handover duration not to exceed 30 minutes, and they have started list their intervention based on this. So before I went to the intervention, I need to highlight how to select the best error prevention tool. And usually we are sharing such prevention tool or hierarchy with our staff before starting the implementation of any projects. Looking to the best error prevention tool is really helping you to look to the optimum level or to reach for your outcome. So starting from forcing functions and constraints, automation, computerization, simplification, standardization will give you the highest level of effectiveness for any intervention. But if we keep our plan within education materials, be vigilant, be careful, rules and policies, you will not reach the highest level of effectiveness. And this was one of the key points during our intervention. We were trying to use the automation, the simplification, the standardization to reach the highest level of effectiveness as an outcome from this project. So the team after that planned their intervention, and they said that there are 8 areas that they need to work on it. First, the standardized sheet for a team leader, and to have a standardized sheet so we will not mix between the assigned nurses handover and the team leader to team leader handover, and to use a Spark communication tool as a reference for us, standardize the role and responsibility, standardize the practice among all units for the team leader, and review the narcotic controlled medication list to avoid or to eliminate the non-moving medication or narcotic medication in the cabinet, and to use the 5S as a lean tool to rearrange the narcotic medication, eliminate any interruptions, and intensive education for the staff to be with us, more engaged, and focus supporting visit to the team while they are implementing the intervention. So the success of the project led to develop a standardized team leader handover sheet as is reflected to you by using the Spark communication tool. So several sessions were conducted before building the sheet and getting the frontline feedback for their needs to be there and what kind of important information, in addition to use a Spark communication tool as a reference, helping us to build this tool. So this tool is reflecting first the 2 kinds of supported information. First is reflecting the unit supported information, which is the number of admission, number of discharge, is there any vital issues that they need, it's related to the unit itself, plus the clinical supported information, which is related to the patient, for starting from the patient identification, situation background, assessment, and recommendation. So if we are comparing the two, the previous practice with the new form or the new practice, you will see in the previous practice, the team leader were using the assigned nurses handover, which is contained of 20 sections. So they are endorsing 20 sections for patients, while the new sheet or the new team leader to team leader, we have 5 sections only to be handed over in addition to the supported unit or unit supported information. Also, the staff were using ongoing team leader handover signage to do not disturb the handover while in the process. And the signage posted while the handover is ongoing to avoid any interruption for the team leader. Also, we have integrated another project with us, which is moving the assigned nurses to the system, to the bedside handover. So they are using the electronic handover for RN to RN bedside, so we'll avoid the merging between the two handover while the team leader doing or providing their handover on the station. So
hello, Lina? We can't hear you anymore.
Yes, I'm
Lina,
with you.
we can't hear.
Yeah. You can hear me?
Yes, all clear.
Okay, good. I will just, because I have shared again, so I'm trying just to, okay, I will be sharing my, my presentation again. I think it's a technical issues. Okay, I'm just trying to reshare my presentation.
Yeah.
Okay, I will share my screen. Okay, no, it's okay. It's okay. You can. Okay, you can stop sharing. I will be sharing from my side. My apology for this. Okay, thank you. Andy, please let me know if you can see the presentation again.
Yes, you're back on, Lina.
Okay, thank you. Okay. I will just go to the strategy because we have stopped on strategy. Okay. So for our strategy, okay, moving to the strategy. My apology for this. Okay, for the strategy, the staff were thinking how to implement those intervention or the planned intervention and using a correct tool so they can reach the outcome of this one. So the best tool to be used is the Bdsa cycle. So the idea of using the Bdsa cycle, it's a four stages problem-solving model. And the team decided to use this model in or in a small scales. So the idea of having the intervention within a small scales is to tackle any issues within the intervention or while they are implementing the intervention and to solve it immediately. So allow them to educate the staff more and to be engaged more with the intervention. So they have started with the first Bdsa cycle, and in the first Bdsa cycle, the staff decided to start with a standard sheet or introduce the standard sheet, standard the practice, and to have the focus supporting visit to the team. So during this phase, this phase, the project team members join the unit or join the clinical handover again by doing another Gemba walk to observe and examine the use of the new team leader handover sheet, noting the implementation of the changes and the presence of any non-adding value tasks so they can eliminate it in the second Bdsa cycle. So after attending the 2 sessions of the clinical handover by implementing the action within the first Bdsa cycle, the staff noticed a remarkable decreased in the duration of handover comparing with the Gemba walk phase. So if you can see here the difference between the Bdsa cycle and the Gemba walk phase, you will see that the staff were having really a significant decrease by 40 to 30% from the Gemba walk average duration of handover. Still, the team did not reach the target of having the handover below 30 minutes, but they are still in the first cycle. So after that, the staff moved to the second cycle to implement, again, more interventions. So they already introduced the standardization of the role and responsibility of the team leader, eliminating the interruptions by using the signage, plus focus supported team were with them. The idea of eliminating interruptions not only by using the signage, we have also revised the assignment sheet to assign people to answer the phone calls and the call bill of the patient. So we will ensure we will not have any interruptions to the team leader while they are providing. So again, the team in the Bdsa cycle were having a significant result, and they were able to reach the 30 minutes of handover and below while they are introducing those interventions. So after that, they moved to the third cycle by increasing the number of piloted units. So we went to other units, educate them about the other interventions, and start again engaging them with us in the third cycle. We have reviewed the controlled and the medication list to remove the non-adding or the non-moving medication, because they are checking those medications as it's not moving, and to reorganize the narcotic cabinet to have the fast moving at the beginning because of the high stock, and then the slow moving medication. So again, in the third cycle, the team were able to notice that they were sustained the improvement of 30 minutes of that duration. So after finishing the intervention or implementation, we'll move to the result or from the statistical wide. So to support the result of the project, the staff went to use the statistical analysis to see is there really a significant improvements between the pre-intervention and the post-intervention when it comes to the duration of handover. So when they are calculating really and examine the between the pre and the post from the statistical side, statistical data were used to support the outcome of the projects by calculating the p-value. And when the team calculated the p-value, they found that really the data is reflecting a significant improvement between the pre and the post test by having p-value 0.008. So also looking to the efficiency, and as you know, the team were looking to the efficiency of intervention and connected with the working hours of the staff. And all of us know that saving healthcare providers time equal to cost saving. So when they were calculating this or comparing with money, they found that saving extra 40 minutes of the team leader handover process will save 8,343 Saudi riyal per month for that organization instead of paying to the staff every month. So this is really supporting the staff, supporting the outcome of the project, that we are not only saving the working hours of the staff, we are also supporting and saving the cost of the organization. So moving to the limitation of our project, and you know, any project is having a kind of limitation. One of the major limitation for us is the system for the team leader. The system were supporting us to move to the electronic handover for RN to RN handover, but they didn't support us to move to the team leader handover because the system is not support a group handover of patients. They are supporting the individual handover for one patient. And as you know, the team leader is not responsible only for one patient, is responsible for the unit itself, plus the major or vital issues related to the patient. And this was one of the limitations for us during the project, that we were not able to use the technology or the computerization, which is level 2 of the prevention tool, but at least we were able to use level 3, which is the standardization of the practice by using lean management. So lesson learned were also listed as part from any paper, that having a standard practice will really help the staff to avoid any variation between the units, and making the flow easier even for the staff. Engaging the frontline, getting their feedback, getting their needs will really improve us for improvements, like such as using the survey to get the feedback and to see that this could lead to dissatisfaction somewhere. So solving the issue immediately and using the current approaches will help us for improvements. Using also leadership skills is very important. How to manage, or the time management, the assertiveness will help the team leaders to lead the unit in an effective way. Plus the teamwork also, to avoid any delay on the process and patient care as well. So our conclusion from the paper was that the lean management approach is effectively improving the duration of handover by eliminating unnecessary steps toward for more efficient, sustainable, and effective communication between team leaders. Moreover, is supporting the hospital in saving additional costs that the extra work hours could lead to. We are encouraging all healthcare providers and settings to go through lean approaches and Six Sigma. All of us know that starting of lean management, the starting were in industrial companies, and recently the healthcare organization were using lean, while in fact our healthcare organization is a complex system and need more lean to eliminate any waste within the process itself. So after our project, we're really recommending lean approaches to be implemented in every single step at our process. So it will really save the cost and the time of our staff. So thank you so much. This is the end of my presentation. If there will be any question, please write it on the chat box or raise it immediately to me. Thank you, Susan.
Lina, thank you so much. That has been so uplifting and so interesting. Thank you so much for your excellent presentation. Now, please, I open the panel for any question to Lina about the lean management. Do you have any question to Lina? Well, I would like to ask you then a few questions, Lina. How was it received? Because I think it is also, you also said, you talked about the behavior. That was one of the points. And I can imagine that that is also a change of culture like it was before. And you can always see that there is especially this handover has a lot of also a social cultural background. How was that received? How did that impact on staff satisfaction? Can you tell us a little bit about that?
Yes, thank you so much for this question. Actually, building a culture of lean management, and it's not easy, even the quality culture within the healthcare organization, and changing the practice. It's really the integration between the quality improvements and the complex system at the healthcare organization. It's not easy. We are building another strategy to change the culture. Plus, Susan, you have mentioned really an important point, which is the staff perception and the resistance. If you are implementing a new approach, you will see there are a level of resistance between the staff. So you need really to engage them more, to have them more with you. So this one of the strategy within nursing services and even within our organization, we are conducting a frequent education to the team related to the lean and related to the quality improvement, by also having the nursing performance management course for 3 days, engaging them, introducing to them the quality improvement tools, and show them some literatures that really reflecting the outcome of implementing or after implementing those tools. So building a culture is very important, especially if the organization or nursing services is going toward magnet recognition. Magnet recognition is really looking to the improvements and looking to how to use the strategy and tools to build a culture of improvement or excellence. So we have it in our strategic plan. So we are not waiting to have an issues to start with. We are trying to spread the culture, then find any area for improvement for implementation.
Yeah, I can also imagine that was just the start. I can imagine you were talking about your Gamba walks. Do you do that now? You were just talking about this handovers.
Yes.
Did it have an impact now on other areas? Do they
Yes.
do now a Gamba walk in how, I don't know, medication is administered or any of this? I can imagine that is like a vehicle and it just perpetuates itself.
Yes, yes, yeah. We are doing, and we are encouraging leaders to do Gimba walk in every single steps. We need to do Gimba walk. It's not necessary to be within the projects. Currently, we are also handling one of Lina projects related to the documentation, to look to the waste in the nursing documentation. And Gimba walk were the first step of attending each process, which is admission process, to see the documentation, discharge, daily, weekly documentation through the Gimba walk. So really, Gimba walk will help you to see on reality. We are not looking to the standard or looking to the perfect policy and the procedure or the perfect flow. We are going to the unit on reality to see what is the current practice. This really will help us to identify the waste in the current practice and to correct it using the proper tool and the strategy. So we are encouraging all to do the Gimba walking every day.
Yes, exactly. We also have a question now from Fatwa Abu Mustafa, and you're asking, was the electronic medical record used while doing the handover, and what was the compliance rate during the handover?
Yeah, electronic handover was separated the project from our team leader to team leader handover, because integration, the electronic handover within the nursing practice, it's not an easy, and it was over more than six months, and we are preparing a scientific based paper on this. Even if you go to see that, you will see that so many articles speaking about electronic handover, but we have a single paper through the nursing journal speaking about integration of electronic handover, reflecting the satisfaction and perception of the staff, of nursing staff. Because implementation of electronic handover, really, it's not an assembly process. We have introduced this as a new practice to the staff before even implementing this on HIS or in our healthcare information system, because the staff need to move. You have a huge movement from paper or the utilizing of sheet to electronic handover. So you need to train them on how to use the devices, how to use the system itself, introduce them to the content, review with the mother company about the content and meeting the standards. So we went actually through a huge project before integrated the electronic handover with our system now. After having this introduction to the staff over almost 6 months, with intensive education using application team. We were using application team because the integration were happening during the pandemic. So it was a little bit difficult for us, but we were having individual and focus visit as recommended by our literature reviews. So to go to the unit and to be with the staff if they were having any difficulty. After 1.5 years, I can tell you that we have a 100% compliance using electronic handover at our city. So this is really for us a great improvement, and we are planning to have it a scientific-based paper from our city.
Super. Did you just have it around your nurses, or were any medical or other kind of staff, like the physicians, physiotherapists, any other therapists involved, or was it just basically based around nursing?
Yes, the electronic handover built on the city through InterSystem or the healthcare, the mother company, from RN to RN, which is assigned nurse to assigned nurse, and the patient definitely involved because it's a bedside handover. But reviewing the content of the handover, it's accessible for all interdisciplinary, because our track care is designed for other interdisciplinary to see the medical record related to this patient and related to their patient. So it's accessible to all, but when it comes to the actual part of exchanging information, it's between RN to RN involving patients.
Yes. Okay. Thank you so much, Lina. Excellent. Thank you for your speech. And now I think you can lean back and enjoy the rest of the day.
Thank you so much. It was my pleasure, really. Thank you. If there's any question from the audience, I think our email will be shared with them, or you can share with me any question later, and I will be really happy to answer them. Thank you.
Super. Thank you so much, Lina. So